Hello everyone, my name is Yahan Li. Welcome back to the ICU training course from pharmacotherapy series. Today we are going to talk about the ICU Liberations, which heavily focused on the PADIS guidelines 2025. Here is our today to explain the practice guideline for managing the pain, agitation, and delirium problems in adult ICU patients, which is really common. Detail the essential components of the ABCDEF bundle, which I will call the A3F bundle afterwards, and focus on updates of the latest the SCCM guidelines on the ICU liberation, and finally to apply those clinical pros to manage critically ill patients. Introduction. Most ICU patients in our practice we would observe they will have certain type of experiencing pain, anxiety, agitations from a lot of the issues happening in ICU admission time, and would suffer possibly from delirium and immobility, and end up with a sleep disruptions possibles. This is not just the small cases. Vice versa, these would heavily impact the patients and even more to increase their mobility and modality. Therefore, the SCCM has published 2 evidence-based clinical practice guidelines, and the third now these years we come up with the third guideline on the PADIS. So first guideline issued on in 2013 with the PAD 3 components. Then 5 years after, there is a 2018 versions with aiding into immobility and sleep disturbance. And finally, this year's 2025, the SCCM PADIS come up with another 5 PICOs EBN questions, and with a great approach that heavily focused on some more on top questions and added to these 5 components. So the PADIS, in short, that by saying this, we are inferring the pain, agitation, delirium, immobility, and sleep disruptions issues in adult ICU patients. And with these 5 main issues in top, that the A through F bundle here, as all you know, the A through F bundle is created to translate SCCM PAD and PADIS guideline recommendations into clinical practice. Now, the purpose of this bundle is to take into integrated approach to managing pain, sedation, and delirium in critically ill ventilated patients in order to facilitate ventilator weaning and mechanically ventilated patients' early mobilization of patients and patient family engagement. Several studies have demonstrated that bundle performance is associated with significant decreases in the incidence of deep sedation, delirium, and restraints use, the duration of mechanical ventilator, ICU readmission rate, hospital mortality, and CU discharge rates. The bundle performance also has a dose-response effect on this bundle performance rate and hospital costs. Published this infographic as you see, which speaks volume about the success of the bundle, specifically mentioned several notable outcomes include a 72 decrease in next-day mechanical ventilation, a 68% decrease in hospital death, and in 7 days, 65% decrease in next-day coma, a 63% reduction in use of physical restraints, as well as large decrease in ICU readmission, delirium, and the likelihood of patients to be discharged to long-term care facilities. It is also important to highlight that not every piece of the bundle has to be implemented to see benefit. Proportionally, as more elements are applied, outcomes improve than capacity. So let's matching the concept from PADIS to the A through F bundle. As you can see on the screen, Each piece of this PADIS guideline corresponds to one of the letters. P is found in A, assess, prevent, and manage pain. Agitation falls into C, making the right choice of analgesia and sedation. D, because it's such a hot topic, keeps its own letter. I, or immobility, falls under early mobility, and S for sleep disruption can fall under a couple different pieces. There are two new letters added to the bundle that weren't addressed in the PADIS guidelines directly. B for performing both the SAT and SBT, as well as F, engaging the family and empowering them to make decisions for their critical care family member. Let's talk about the section starting from the beginning. Alright, the ICU triad is the conundrum our critically ill patients face. It is all integrated in more pathways than I can get into today. It really reminds me of the trauma triad of death with three key features: pain, delirium, and agitation that feed off each other to directly increase the risk for outcomes in death. It is easy to gloss over these items in our daily workload, forgetting the contributing factors which could lead to lack of appropriate intervention. Plus, don't forget these symptoms, whether pain, agitation, or delirium, can lead to very long-term impact on our patients, including shortly increased endogenous catecholamine activity, oxygen consumptions, hypermetabolism, and immune suppression. As you know, I am a clinical pharmacist working in ICU, so my daily practice oftentimes is to approach a bedside, go rounds with our ICU folks to get the patient together and ask them, what is the goal to take care of our patients right now ventilated? Since he or she is ventilated, should we just keep these patients asleep, look comfort, but actually not so sure, to knock out the patient, to keep them quiet, or should we look at the real chart, try to identify and diagnose differential? And then, if that is resulting from pain, if that is the pain resulting in the delirium or discomfort agitated, then let's comfort the patient first with better appropriate analgesia. So please, as the folks here, they are very, very important to take care of the pain sensation first. Here are the common but not all listed painful procedures in ICU, as you can imagine. Will there is any IV line insertion? Is there any like peripheral blood draw, any stat blood draw, or any just the line or the catheter removal, any exercising from respiratories, requesting the drug, or even through the usual care from mouth care, eye care, bathing, and turbing. This could be painful to the patients, and especially for the intubation process and even extubation. So keep in mind that our patients lying on ICU beds, oftentimes, if the patient is intubated, especially suffer from pain. That is common. So how should we better assess the pain? Is it objective enough for us to ask properly? So here is the chart flow I'd like to share with you. First, to know if the patient can self-reporting themselves. If so, ask them, do you feel pain? And can the patient quantify the pain? Like how much? What is the scale? Is it? If so, then we use the numeric rating scale, the NRS scale. If no, then just let it okay, just yes or no assessment. But if the patient is ventilated and cannot verbally express themselves, then, or if the patient is suffering from any of these situations that has a very deep sedation score, RASS is -4 to 5. If the deep coma, the GCS score is only below 8, or if patient is on the neuromuscular blocking agent, then of course they cannot respond themselves, and then we probably could not access the pain feeling, but we should not neglect the fact that patient is not suffering from pain. But if the patient is not under these circumstances but cannot express, then there is another tool that is called the Clinical Care Pain Observation Tool. That is the CPAT. This is very useful. So this is the NRS scale that rating from 0 to 10. We ask our patients what is the maximum pain feeling. Please score from 0 to 10 and to see if they can quantify. And if the patient cannot communicate, then we use the behavioral assessment by using checking following indicator, whether the patient's facial expression, any body movements, any muscle tensions, and also their compliance to the ventilated. The RT, the respiratory therapist, oftentimes talk to you saying this patient is not synchronizing to the vent. So these are all the possible indicators. It possibly indicated the patient had the pain causing as the contributing factor. So the CPAT should be accumulated and keep it from 0 to 2. Any point over 3 is we would call that is having significant pain issue and need to be addressed. Here are some guiding principles for the pain control, and I try to link those to the A3F bundle. So for assess and treat pain is the most important, is always your priority. Prior to any initiating goes to the sedation or the sedative medications. And it should better be protocolized, like based on the pain assessment and management. And remember, for these pain protocol need to be assessed regularly, routinely. Like for my ICU, we often check patient with the CPAT score or BPS score every 2 hours. And for the beyond the assessment, then let's go to the choice of analgesia and sedation. So again, here you can see it's always to dealing with the pain, assess and treat it first, and then we can move on to the agitation therapy. So principles number 1 is always analgesia first before sedation, and any medication used for keeping patient calm and ease should be analgesia first and based beyond the sedative its own. And in terms of the analgesia choice, opioids is always the first line that be most effective pharmacology treatment for the ventilated patients suffering from pain, but it's not the only one. So this is the current guideline PADIS. For in terms of the pain section, there's no much updates. So we pretty much stick to the principles. If that is the pharmacological choice, we would like to go to not only opioids, but better multimodal. But still, we should know what's the difference in terms of each medications. So it can be properly selected for other patients based on their characteristics. So the opioids is, in terms of the route, we prefer doing the intravenous. So the ideal opioids are first line for the non-neuropathic pain. If administered in equivalent doses, remember there are no difference among different opioids in terms of analgesic efficacy, but they have different side effects or different the PK properties that should be different, and you should know before you choose a certain opioid. And for the non-opioids analgesics, should be considered in order to decrease the consumption, to decrease the use of opioids, which include like whether acetaminophen, the NSAID, By the onset, we should exclude the COX-1 inhibitor. It should not be considered in terms of the ICU pain management according to guideline and its side effect. And if there is neuropathic pain, then anticonvulsant can be selected if appropriately. And plus, whether ketamine or some local anesthetics has all the analgesic effect. And then for non-pharmacology, it has very limited evidence, but just use it if you feel comfortable and if you can provide a service, like including relaxations, the massage or some music therapy has some conditional and very weak of evidence to support it. And plus, if the pain in the ICU is causing from any procedural pain, then we can do as the preemptive treatment, like just a bolus dose with the lowest effective dose opioid before any chest tube insertion. I'll give my patient like a 0.4, which is like 40 milligram ampules of morphine PRN before any chest tube insertions, if the physician feels okay. And let's dig down to these opioid agents. So keep in mind that in terms of the IV form opioids, there are common selections from fentanyl, remifentanil, morphine, and hydromorphine. For each common dose, I will list it here for you. Oftentimes, we would like to give a loading dose first, then put patients on a continuum running IV drip that is maybe on a IV pump to keep going on the maintenance dose. But the dose range, it to be keep in mind that we are always pursuing to the lowest effective dose. So it doesn't have to always be put on the highest range of the maintenance dose. We can try if the patient reach your target CPOT regularly, for example, then we can taper down the doses and then even try to turn off the analgesic. All right, so in terms of this property, fentanyl of all has the most significant, the fattest one onset, and have a proper duration. Instead of like the morphine or hydromorphine has a longer duration time, but takes longer to onset. And in terms of the potency, has a very different in terms of different opioids, so that also influence the dose to keep in mind for that. So the fentanyl, because it's rapid onset and often no accumulation in renal failure, that we prefer to choosing that as our continuous running agent. And the meperidine, which I wasn't listed here, should be avoided because this neurotoxicity is easily leading to any like seizure-like adverse effect or neurotoxicity event. And here are more PK properties I offer to you that you should keep in mind. Fentanyl that has a rapid onset, and because it has less histamine release, so it will leading to less hypotension compared to other like morphine. And fentanyl it accumulate with when with a prolonged infusion because it is highly lipophilic. But it is also to keep in mind that several if a patient run into adverse effect that is skeletal muscle rigidity, that is often due to its prolonged infusion and accumulated. So if any situation happens to that, just stop the fentanyl and maybe can give some rescue medications. And for the remifentanil, it is pretty special for its excretion metabolized, that it's not really liver metabolized or renal excretion. However, it is affected by organ function because it is metabolized by plasma esterase, the other enzyme. And its glycine excipient may accumulate in renal impairment patients as well. And for the adverse effect, which is common from nausea, constipation, and respiratory depression, bradycardia. For morphine, is probably the second, on top of fentanyl, it probably be the second agent that is the most common choose. Keep in mind it because it's relatively not that lipophilic like fentanyl, so it has slower onset time, but it has active metabolite, so it's not accumulated due to the prolonged infusion, but itself can oftentimes accumulate from its active metabolite in any hepatic or renal dysfunction patient. It has less drug interaction, but because its mechanism triggers more histamine release, so patients sometimes may have the skin rash, but keep in mind it is not really allergy, it's just the histamine release effect. And as for hydromorphine, it can accumulate in hepatic or renal dysfunction. It has the neurotoxic metabolite, so be less choice, though it has less drug interaction as well. But it can be really highly concentrated, so keep in mind we would like to avoid it. If the patient is fully restricted, then probably not choose hydromorphine for patients because its neurotoxic metabolite is highly accumulated in terms of very high concentrated situation. What if the patient suspect running through opioid and opioid overdose? Here is the IV form that you can probably choose. This is naloxone, or it has the IV form, or some international formulation have the nasal spray as well. So naloxone is a synthetic concurrent of oxymorphone. Is pure and competitive opioid antagonist that has a very high affinity for the new opioid receptor, so it allowing for reversal for the effect of opioids. And it's good because there's no absolute contraindications to use naloxone in an emergency, but we still should be keep in mind if a patient is long-term or already dependent on opioid, and then these approved reversal from the opioid effect may cause the patient run into an acute withdrawal from opioid that has these discomfort sensations from the anxiety, aggressions, nausea, vomiting, pain, and rhinorrhea. That should be kept in mind, maybe infer the patient is having an opioid withdrawal. These are the common non-opioid agents for your reference. So keep in mind, each medication has its limited side effects and mostly related to the metabolic pathway. So here is more detail for the reference. Acetaminophen, we know that it has a maximum dose should be not dosing more than 4 grams per day to be safe, and maybe significantly, if a patient is significant hepatic dysfunction, then it is contraindicated. Ketamine itself is a very interesting medication that has the high drug selection effect. I will introduce you further later, but it would definitely because it's a toxic drug itself. So any psychosis, hallucinations is a side effect, and you probably should carefully monitor your patients. You don't want the patient to get to the euphoria just because the ketamine for the pain analgesic. And for the NSAID here, we do not use the COX-1 inhibitor. And for the ketorolac, ibuprofen, we know they have the renal toxicity, is easily causing an ulcer from the intestine or the GI tract. So, and if the patient, especially for the ICU surgeon case, is just have the peri-operative pain from the cabbage, the coronary artery bypass graft surgery, then these are contraindication medication for the pain. Any for the anticonvulsants like gabapentin, carbamazepine, and pregabalin, these are very, very helpful for the neuropathic pain if indicated. So let's dig in some more detail probably for this analgesic. Ketamine, its place is interesting in ICU care. It has a lot of different effects, including adjunctive pain control, agitated, it could be one of the sedative, and also useful for alcohol withdrawal, status for epileptic seizure case, and also as the sedation for the rapid sequence intubation, the RSI indication. Is an NMDA antagonist that would generate these excellent helpful for the ICU, but with its counts as well to keep in mind. First, it has the direct and a negative inotropic effect that would probably decrease the CI or CO, and it has a central sympathetic stimulation, a neural catecholamine uptake inhibition effect. So that's why ketamine is unlike other analgesia or any sedative. Ketamine has less hypertensive side effect. That is a good point. However, it is also not that easy to induce a respiratory depression. But it can possibly increase intracranial pressure, so early IOP. You have to encounter situation running that. Keep in mind the patient may not be should be contraindicated for that certain diseases. So contraindication as acute psychosis in recent or acute AMI case or acute decompensated heart failure case is absolute contraindication. But for the relative following, you should be precaution or be not to select if you have other choice, which including if the patient, because it has easy emesis side effect, if the patient needs to be endoscopy to check for the posterior pharynx, then cannot be a proper choice for using ketamine, or any trachea stenosis, any pulmonary infection, or the cardiovascular disease like hypertension, heart failure, angina, or a CNS issue that easily brings out an ICP that has the IICP, like the intracranial bleeding case, hydrocephalus case, syphilis case, or a glaucoma, or the porphyria. It also has been several case report suggesting not using ketamine. Okay, and let's move on to the agitations. So what is the indications or what brings our ICU case that have the agitated or anxiety, and what's the indication needed for sedation? So the sedation here is useful for attenuating any fear, possible anxiety, to facilitate during the several invasive procedure that can that could be high tension, and also if the patient has a severe respiratory failure and is not synchronizing from the ventilation, that sedation may be needed, and it is mandatory that if the patient needs to use any neuromuscular blocking agent, then sedation has to be be on first as an important adjunctive. If the patient has a status epilepticus or any like intracranial hypertension event, that is good, and also for the facilitated terminal care. And as for the assessment here, I would recommend you the two scales. First is the ROS, the Richmond agitation sedation scale. It could be rating from down -5 to +4, and we depends on if the patient is response to any verbal stimulation or only to physical stimulations, or the patient doesn't have to be stimulated but is very agitated by himself. So any RAS score, remember, any RAS score from -3 or more should also be assessed for both pain and delirium. Because remember, as the triad that we just mentioned, a possible agitation condition is probably contributing and predisposing to pain. So let's go with these two concepts hand in hand together. And any agitation and sedation assessment, if regularly implemented, it has better improved outcome as evidence suggests that. So publications have been showing this agitation control provides a sedation strategy, provides shorter duration of mechanical ventilation, decrease the ICU or the hospital stay, decrease the delirium or the long-term cognitive dysfunction. And so we should routinely evaluate in all ICU patients, not just the ventilated ones, but also non-ventilated. But mostly, like key concept here is pretty similar as the analgesia is we do not want to over-sedate our patients. So evaluate first assessment and then give the minimized sedative medications as required. So the key concept here, please note that we have two different goals of sedation, a light sedation or deep sedation. So a light sedation, which means that the goal should keep at from -2 to +1. So evidence has suggested that controlling and targeting at light sedation can be compared to over sedate or deep sedation. The light sedation choice is better in providing shorter ventilation days, shorten ICU stay, and also increase the physiologic stress response in the patient. So you do, which means when you evaluate the patient's conscious status, you can you can make sure that patient is not aroused because of medication's impact. If that makes sense to you. So keep patient at light sedation is the primary practice nowadays internationally. So how to provide possible over-sedation, how to prevent, an over-sedation event. There are two protocols that I highly recommend to you that you can consider to come up with your own. First is the nursing protocolized one. That is to at least be regularly monitored and check at least the RAS score at least every 8 hours, every shift, if possible, and keep it as the goal at positive from any point from -2 to +1. That is the first one, and maybe you can add on one more, which is the daily sedative interruption, DSI, or the spontaneous awakening trial, that is called the SAP. So by saying this is we do this interruption sedation daily. That is to monitor, the aim is to monitor the conscious level daily by make sure the patient, if have encountered any of these emergency in the ICU, like an expected complications such as an ICH, intracranial hemorrhage, or the stroke that's leading to the unconscious status, we can, while we turn off sedation, that we can make sure the patient's arousal is possibly indicating some other serious complication that is happening, that we can make proper intervention in time. And also by doing the daily interruption of sedation, we can adjust the adequate dose to the target level to minimize the dose to the lowest effective one. So here is one trial from JAMA. I tried to compare the NP targeted protocol or DSI or combine both together. So and we can see that the protocolized sedations only versus the protocolized sedation plus daily interruptions is all not really significant different from here, but it's itself compared to the placebo doing nothing is all better. So from the 2018 PADIS guidelines suggest us for the ICU critical ill patient and intubated one, whether the DSI protocols or the nursing protocolized target sedation can both achieve and maintain a light level of sedation and should be considered to conduct in your facility. However, keep in mind, it's not all every ventilated and used under sedation patient has the eligibility starting the SAT daily interruption. So do not doing daily interruption if have the following on-screen criteria has met. That's including if the patient's current sedation is very agitated status, and the ROS score is above goal, and if the patient already have a very legitimate need to target the deeper sedation, to the physician said as target the ROS from -4 to 5, and with the least common situation with patient has the an active seizure, has the alcohol withdrawal syndrome that needs benzodiazepine. If a patient has the need to use in a neuromuscular blocker agent, then we have to sedate the patient to a very deep condition first, because we would like to make sure the patient is entered a coma or arousal status before, and we do not want our patient has any chance to feel him or herself can feeling everything but not able to move a finger. So that is the art of using putting a patient on the neuromuscular blocking agent to starting a deep sedation first. All right, and then if a patient has a elevated ICP, that definitely need target deeper sedation to decrease the metabolites in the brain. And other condition, if a patient is need to receiving ECMO and assessed by physician's decision. And if the patient has a very high FiO2 ratio, like for our hospital, we target more than 60%, or the PEEP is more than 10, then do not enter SIP that day. Otherwise, if a patient has under high stress, like just having a heart attack, having a myocardial ischemia in prior 24 hours, let's not doing that. So for in the A through F bundle, B in terms of conducting both SIP and SBT. So here is the process that we do routinely daily. So we do screen for the eligibility for SIT daily. If the patient can enter the trial, then we will conduct the SIT by turning off both analgesic. We will turn off both fentanyl pump and the analgesic and the sedation. Like for example, the propofol pump, we would turn off both, and we would watch. The nurse would monitor the patient for like 30 minutes. If the patient is passed, and then I just go to the SBT trial, which is called a spontaneous breathing trial. And if a patient, according to the respiratory therapist criteria, and if the patient passed SBT, then he or she may be extubation that day of time in the morning. So what is the important indicator suggesting patient fail from the SIT? That is, a patient after an observation within 30 minutes, had the very significant anxiety, shut up, agitated, or the patient start tachypnea, like respiratory rate is increased for 5 minutes more, and starting having desaturated, like the SpO2 down less than 90%, or have the new onset arrhythmia or any symptoms of respiratory distress, like the tachy, bradycardia, accessory muscles is under the strain, abdominal paradise or diaphoresis, then that's called the SAT failure. So important thing to keep in mind is if you have witnessed the patient fail from the SAT that day, which means the patient may still need some analgesic or even some sedative, then you can go on and turn on the analgesic pump first. So do not both to restart it analgesic and sedative, starting from half dose of the analgesic, and to see it, because the aim is always trying to find out the minimum effective dose. So to resume with the fentanyl pump with the 50% dose, and to monitor the sleep part, and then adjust if the patient furthermore need any sedations based on the RASS scores, for example, from that point. Alright, so here are some choices of sedative. Like I put here is can categorize into BCDs and non-BCDs. So any BCD, the most common one commonly used, that can be administered into a continuous pump. The continuous IV drip is amidalazine and the lorazepam. So these two have the relatively slow onset, and also it has, especially from amidalazine, it has an active metabolite that is the same running to the issue that is easily accumulated in a patient if has any hepatic or renal dysfunction. And for the lorazepam, although it does not have an active metabolite, however, it has another side effect that should be kept in mind that I will introduce you later. And as for the non-BCDs, that we would oftentimes have a propofol or dexmedetomidine as our choices. So propofol is a NMDA receptor blockade that reduces the glutamatergic activity. It has very short onset, and compared to dexmedetomidine. And as a propofol, to keep in mind, I'm not sure about which product that you use in the Hargeisa Group Hospital, but this is our product in Taiwan. Like as you can see, this solution is very thick and white color. That is because it has contains a lot of fat in it. So it takes the calories into consideration, and more thing to that, it is because it is very rich in fat. So once you open the ampoule, you open the product, and be aware it has to be really stick to the ASD principle, the stereo principle, that it has a risk of infections if it is not kept in the very sterile condition. So we would discard the solution whole set, including the IV line, every 12 hours. That is a protocol in our hospital and in a lot of different hospitals as well. So discard the medications after 12 hours because once passing that, it is very rich, remember? So it's easy to generate the germs, the bacteria, and the patient will be highly risk running into an infection from using this. And because it's rich as well, and it's actually already compounded as ready to use, so we just doesn't dilute it, so it just directly open the drip and accumulate into a bag and then use it, or contact to attach to a pump. But if you need to dilute it, then evidence just suggesting diluting with glucose. The concentration must be still keep in mind with more than 2 milligrams per milliliter, but used with even less restraint hours, used within 6 hours. All right, so and the last one is the dexmedetomidine. That is the product is Prestige in Taiwan. That it is an alpha-2 agonist that has a very short duration and is non-active metabolized, so it's less accumulated and is good for non-intubated patients. Comparing these sedatives, it all has several hypertensions impact, especially for propofol and dexmedetomidine. But in terms of the respiratory depression, remember it's BCD that has a higher impact compared to propofol. And for the dexmedetomidine, it has the least respiratory depressions allowed to influence the patient. So sometimes if the patient has starting the dexmedetomidine pump while intubation, but is extubated, we would feel comfortable to continue to let the patients run this dexmedetomidine pump because it has less respiratory depression side effect, but just to be still have to monitor for other side effects. So what are the others? For the BCDs, it has the we know is in the Duke criteria, the Beers criteria, sorry, that BCDs leads to delirium, increased delirium risk, and also easily over sedation the patient, especially if it has been already accumulated through the active metabolite in renal hepatic failure case. And for the midazolam, it has an amnestic effect as well. And for lorazepam, to be noticed if it will sometimes generate and we call the PG, the propylene glycol toxicity, if the estimated minus if the gap between estimated and the measured osmol is above 10 to 12, that is time you should be cautioned that whether a PG toxicity has presence. I will show you later. And for the propofol, should be keep in mind several things. One is rich in fat, so we not only to discard the IC set every 12 hours, we will monitor the patient's TG, the triglyceride, every 3 to 7 days to make sure if a patient is not running into hypertriglyceridemia status, and monitor for possible pancreatitis risk. And it often have a urine discoloration, like the pictures that have the urine being colored into green, but it just from the medication's metabolite issue, but it's not really causing damage to the patient. But what should be noticed is the PRES. It's a propofol-related infusion syndrome. It has a very complicated event if you run in too long. I will show you later. And as for dexmedetomidine, not only to the hypertension side effect, it is easily observed with bradycardia. So be aware if the patient just having an arrhythmia event or has some CV issue, like definitely look at for the heart rate. Do not, if the patient has a tends to start showing bradycardia, then probably not continue the dexmedetomidine, or you can just shut it down and keep it on for several hours until the heart rate is stable again. And sometimes if dexmedetomidine starting running with a loading dose, at the very beginning, you can see the patient has hypertension. The BP will goes up. So some more tips for you. The benzodiazepine antagonist, again, for its possible suspect of sedation. And again, here we have a flumazenil with a common dose as listed here for your reference. And again, the concept of using the flumazenil is not really to address overdose issue from the BCD, because it has a really short half-life of flumazenil, only less than 1 hour. But compared to the BCD's half-life is much longer. So that means to administer flumazenil is not really aimed to totally correct or totally reverse a BCD overdose, but instead we oftentimes use it because we would like to differentiate whether patient's unconsciousness status, for example, is because of BCD or not. It's because of the sedative from the benzodiazepine, or it's not the medication's effect, but is the patient really has other stroke or ICH condition that we need any urgent management from that. So giving a flumazenil is mostly for differential diagnosis, then really correct and oversedation. That's for your reference. And also, if a patient has these conditions, then maybe flumazenil directly or reverse a BCD is not a good idea. That is, a patient, if I has epilepsy, I need BCD so much to treat to control, or if the patient is head injuries, is the ICH patient has an intracranial pressure and I need the BCD, then the approved flumazenil can cause the patient start seizing or alter its cerebral stability, that the blood flow may be impaired. So just be aware of that. And as for lorazepam, the PG intoxication is because the PG is majorly metabolized by the liver through this ADH enzyme, and in many cases, patients have diuresis, renal failure, lactic acidosis condition. The PG's intoxication may start to show up, and that is clinically presents by this following: that there's acute tubular necrosis, or CNS depression, or cardiac arrhythmias. That is really should be kept in mind from the lorazepam. And why we emphasize lorazepam, because as you can see in this table, compared to all other common or uncommon medication, that lorazepam is the medication that has the highest amount of the PGs in terms of the concentration. So several risk factors of running PG intoxication, including several risk factors of PG intoxication, inferring a very higher dose of lorazepam or the higher rate in the presence of alcoholism, or it has a hepatic renal disease again, or under metronidazole use. And for the cardiac infusion syndrome, its possible mechanism is not yet to be ensured. However, it's being highly related to possible mitochondrial dysfunctions, impaired any fatty acid oxygenation. The pre-symptoms clinically can be very diverse. So various symptoms can be mimicked to a pre condition. So including bradycardia, any CV sudden collapse, a high anion gap metabolite acidosis, or these are the following symptoms for the peripheral-related infusion syndrome. As you can see in the yellow box, the clinical presentations is various and hard to distinguish at the very first time. So keep in mind, if any risk factors that propofol has already administered longer than 48 hours with a really higher dose, and it should be keep in mind with any symptoms coming up, especially with any CV sudden collapse, bradycardia, any high anion gap group metabolic acidosis, rhabdomyolysis that we can monitor the CPK with a certain level and with the lactate for the acidosis, hepatomegaly and lipemia and the AKI is all included in the syndromes of the propofol-related. And some special introduced to the dexmedetomidine and emphasize on this medication because this year the SCCM PADIS guideline have bring heavily focus on it. Anyway, the mechanisms for dexmedetomidine is the alpha-2 selective adrenal receptor agonist. Its activations of the receptors in the CNS inhibits neural firing, causing hypertension, bradycardia, sedation, and analgesia. It inhibits the release of norepinephrine, terminating the propagations of pain signals. So that's why dexmedetomidine has a partial analgesic effect. So sometimes providers tend to select dexmedetomidine if available for the opioid sparing, but keep in mind if a patient really has a pain issue, and oftentimes using dexmedetomidine alone is not adequate and is not suitable for the pain need. So in that circumstances, opioid still remains the first line agent for the analgesic use. And dexmedetomidine therefore has a meaningful respiratory depressions, and that brings the patient to very easy arousal status, and also is related to this efficacy that it can reach for the light stations only. So it has no role in any target to the deep sedation. So keep in mind for that. Therefore, following our situation, that should avoid selecting dexmedetomidine with any AV blockade, any bradycardia, any refractory shock condition, and that is because is causing the hypertension from inhibit the norepinephrine from releasing. If the refractory shock status at the very first point, dexmedetomidine may even decrease the blood pressure from that. This year, the SCCM PADIS recommend using dexmedetomidine over propofol. But before this year's update, is just more generalized recommend selecting either dexmedetomidine or propofol, but definitely over BZD. So I will show you some reference with these updates in years. So the choice over whether non-BZDs or BZDs is firstly addressed in 2018 SCCM guidelines suggesting either propofol or dexmedetomidine are preferable. And the role for the BZDs are remain and restraints mainly for those with alcohol withdrawal syndromes and status epilepticus. Here I listed two trials, the MENS and the STATCON trial, using dexmedetomidine as example for non-BZD compared to BZD. Here in the MENS trial, that can see using dexmedetomidine trial in an ICU settings can have a significant more delirium-free days and coma-free days, and also has a significant less prevalence of delirium proportion. But it's no difference in other outcomes, including the ventilator duration, ICU duration, or the 28-day mortality. For the second trial, dexmedetomidine reached the lower prevalence of delirium significantly, and also had a larger delirium-free days, shorter time to activation. So these could be related of emphasizing to kept non-BCD in front and BCD lastly. And whether to use dexmedetomidine or propofol as the first choice, it has been debated for a couple of years since 2020. And this year, the SCCM come out with a systematic review and meta-analysis composed of up to 29 RCTs with 3,087 patients that is threading. Most of the RCTs target the light seditions, and here are the main results from the meta-analysis I listed for you. That with the green bar is dexmedetomidine compared to propofol in light sedation control, significantly had the less risk ratio, had less risk of delirium and less duration of delirium hour. However, as we can imagine, dexmedetomidine itself had a higher risk of having bradycardia event, so it should be kept in mind. As for others, mortality or ICU ventilator duration or the hypotension, dexmedetomidine and propofol have a similar outcome. Therefore, in PADIS guideline this year, the panel suggesting dexmedetomidine over propofol for these sedation ventilated patients, adults, where light sedation and or reduction in delirium are of the highest priority. So let's go for the delirium. So delirium is really serious disturbance in mental abilities that result in confused thinking and reduced awareness of the environment. The starting of delirium, if you have ever noticed any ICU patients in your setting, is often usually rapid within hours or few days that we call the ICU syndrome. Any contributing factors including severe or the chronic illness status, changes in metabolic balance, any metabolites, any electrolyte ED issues, of course medications and infections, or the substance can often impact. Delirium symptoms can be spared from a reduced of awareness of the environment that we sometimes calling disoriented, or poor thinking skills, behaviors change and emotional disturbance. And delirium is associated not just the behavior itself, but up to threefold increase in mortality, increased cognitive decline, delay in cognitive recovery, and increased likelihood of discharge to nursing home. Here is the process for prevention. As the most important steps is to prevent these issues from happening, that we can be better selecting using, for example, the non-pharmacology measures according to the modifiables to reduce the medications like that can facilitate a delirium, like for example anticholinergic and also the BCDs for the elders, of course, especially. And also try, if possible, to avoid the physical restraints. And for the pharmacologic measures, that is favor the nighttime race is could be improving as the sleep sections as melatonin that is infrared this year, and also some basal antipsychotic treatment if needed. As for identification phase, for the delirium can be categorized into three types, including hyperactive, from hypoactive, and the subsyndromic delirium. The scales including the CAN ICU or the ICDSC. CAN ICU, if that is negative but with 2 positive points in it, or if an ICD-SC score scaling from total score below 4, that means 1 to 3, is considered subsyndromic. And the goal for our care for the ICU patient is have a negative delirium. So in CAM ICU, we want a negative as a final result. And in ICD-SC, we would like a -4. In terms of the treatment, still the better go for the non-pharmacology measures first. But if a patient's running any medication, then we have to differentiate whether it's a hypoactive type or a hyperactive type delirium. But the pinpoint is if that is hypoactive and if that is persistent, and the medication need is probably can try some quetiapine or risperidone as an antipsychotic. And as for the hyperactive, if can try using the alpha-2 agonist like dexmedetomidine, clonidine, to calm down and ease the patients, and neuroleptic in terms of that haloperidol or quetiapine that is often used, olanzapine and risperidone. So you can see for any antipsychotic, I can target both hypoactive and hyperactive form. Right, and if that is really refractory delirium, then we may be consider using the valproic acid as a mood stabilizer. So here is the module for the ICD-SC, the Intensive Care Delirium Screening Checklist. It measures the several indicators from the alertness of consciousness, dislocation to the orientation, if or not disorientated. And if it have any psychosis symptoms such as hallucination, like any psychomotor or retard agitations, and or any verbal or any mood inappropriateness, and if any disturbance to a sleep cycle as well. So again, the delirium is been diagnosed if the ICD score is more than +4. If that is below 4, that can be but not 0, then that can be considered as a subsyndrome. Here is the manual for the CAM ICU. That the algorithm composed of 4 domains from changing of the mental status to the alertness level and inattention and disorientated. And that is a delirium is being diagnosed if this module has been reached from at least 3 points. So that has to, and 2 of the 3 points has to go to the first 2 domains. If the patient needs to both have a fluctuated mental status and also an altered level of consciousness, then go try to either inattention or disoriented. And that is composed of at least 3 points or more, and that is called a delirium or the positive of CAM ICU. So B is mostly important that the CAM ICU should only be measures in those non-intubated patients, because the patient has to, in order to answer your questions to respond whether he or she is disoriented, the patient has to be verbally able to respond, to communicate. And for any non-pharmacology treatment here, unfortunately, so from the 2025 SCCM PADIS is not really able to come up with specific recommendation of routine use antipsychotic or not. So the same back to the primary prevention is the key. But if the delirium is witnessed, and still we can try starting from non-pharmacology intervention as the first step, with following maybe minimal but important steps, including regularly implementing the SIT and also reorient the patient, tell the patient which date is it today, what time is it now, and which place, which hospital name you are in, and why you are here, to emphasize the key importance to the time. And also to perform early mobilization, to promote the effective sleep awake or an awake cycle, including to minimize any nighttime noises, stimulations, to minimize possible benzodiazepine use for sedation is all helpful. Pharmacology treatment for delirium here, I only list antipsychotics for you. Oftentimes we would choose the oral form is more preferred than haloperidol. So an oral form in here, including from risperidone, olanzapine, or quetiapine, is all can be chosen. And of all these, quetiapine, the last one, quetiapine is the medication that has the most flexible, the highest flexibility in the dosage. And haloperidol has an oral form and also an IV form here. Sorry for the typo, I only list IV. However, the haloperidol itself, if administered intravenously, it should be important that has compared to other oral form antipsychotic, an IV form haloperidol it generates a significant arrhythmia risk, and overall adverse events for these antipsychotic, including arrhythmias, serotonin syndrome, NMS, the neuroleptic malignant syndromes, and APS, extrapyramidal syndromes, or the oversedation. Then we move on to the immobility. To enhance early mobilization is not just to start letting a patient doing like really high intensity exercise like running or sprinting in the world. No, it means trying to mitigate the long-term effect from stay in ICU bed and acquiescence and ICU acquired weakness. Currently, however, the current recommendations fail to recommend very specific regimen in terms of mobilization frequency or intensity or duration, but just very vary. So here, this year, the SCCM come up with a definition for the mobilization and enhanced. So any terms related to mobilization defines as the process of moving oneself and maintaining or adjusting positions is all included. And enhanced here by means saying anything more than a unit's usual mobilization or rehab. So it may include variety from cycling, stabbing, or any early or twice daily, etc. Extended durations, or the protocol is called so-called enhanced effort. Here, PADIS this year suggesting provide enhanced mobilization rehabilitation over just doing the usual care to the adult. So we will still have to wait for more evidence to come out to address the heterogeneity, and hopefully there will be more precise recommendations on the ideal mobilization form and dose, timing, durations, and methodology. But here you can see from the meta-analysis composed of more than 10 RCTs this year that conducting an enhanced mobilization compared to usual form is really had a significant impact in terms of reducing ICU acquired weakness with high certainty. Last section is the sleep disruption. So why sleep disruptions? You can not hard to imagine that a poor sleep, we can all agree on this, is a common complaint and source of distress for many critically ill patients and even healthcare professionals ourselves. Sleep disruptions can be severe and is categorized by sleep fragmentation, abnormal circadian rhythms, increased or light sleep, and decreased of the deep sleep. So sleep is considered a potential modifiable risk factor influencing recovery in critically ill adults. And the interplay of medication, critical illness, delirium, and cerebral perfusion and sleep is actually quite complex. That is an important area under the current research. But here you can see we still can figure some modifiable risk factors and trying to use that, especially during the ICU admission. So from any pain or very sensitive to environmental stimuli, any health care related interruptions, any psychology factors, respiratory factors, and medications can cause poor sleep quality and quantity. And there are not very high level recommendations, but with very low quality of evidence can suggest you to try this effort as a non-pharmacology approach for better sleep, including compare to pressure support mode, turn the ventilator to a control mode at night if that is not at a phase for a weaning or trend exercising. Aromatherapy, acupuncture, music, and reducing any possible noises and light to keep the light as dark as possible is all better, providing better smooth sleeping environment to the patient. As for the medications this year, the SCCM highlight the role introducing melatonin. So melatonin is a very interesting substance. It's not really a synthetic molecule. It just in our endocrine, our hormone systems can all secrete and come out with melatonin if in a proper setting of our daily practice. So melatonin, according with any additional supplement, regardless of any dose or duration or frequency, compared to not getting melatonin from more than from up to 30 RCTs, here can have not so significant in improving sleep quantity, but most importantly, it can provide the pool data suggesting that melatonin use has less proportions of delirium event. And other minor significant outcomes, including the have a better perceived sleep quality and near like half day less of the ICU stay. In terms of these other outcomes, there is no significant difference by using melatonin. Therefore, PADIS guideline this year suggests with using melatonin or not using in the ICU patients, adult, conditionally with low certainty of evidence. But due to the heterogeneity and also other administration's availability issues among different RCTs and countries, there is heterogeneity in terms of the dose durations or frequency recommendations that are still limited. Finally, according to the A through F bundle, we are at the last one. Letter is laid off. The family engagement and empowerment emphasize collaboration not only the medical team, but also with the family. So family can contribute and collaborate, provides an effective approach, planning and delivering care. Family are the important role. Don't forget that fact in facilitating patient care by providing alleviate effect, comfort patients and family concern, and they help improve patient outcomes if we let them, and support respectful approaches to the final wishes when there is the time. And the action points by using the family engagement, including to come out with your own institution's policies to support family visitation, and to hold a routine meeting with family and constant provide frequent communications in between and involve family in the direct patient care. Summary of all, we talked about the PADIS, the PADIS, and the quite useful bundle from A through E. So there is a necessity on ICU liberation with a multi-facet patient-centered approach. So some medication-related point I still like to emphasize in the end, including to choose to prioritize pain management with analgesia sedation concept, and the principle goes to analgesia first, and employed multimodal analgesia techniques. And for sedations and for the light target, dexmedetomidine, for example, is preferred suggested this year than propofol, and or these two are better than BCD its own. And for the B is both SAT and SBD, the daily assessing the need for sedations and ventilator weaning. Prevention for the delirium, among whether antipsychotic use or not. So far, we believe prevention is the most important key of all. And lastly, for the E, early mobility, and F, family engagement, we as the ICU aim for pursuing better care quality. We must incorporate the E and F to address the physical and emotional effects of our critical patients' needs. So thank you for